I'm afraid I do not. My numbers said there were 10, and so we'll have to compare data later, Dr. Cawthorn. So, and in fact, I'm going to come back to something else that Dr. Cawthorn said in her presentation near the beginning, and I'm going to come back and circle back to it. But she talked about, in that milestone slide, a very collaborative process. And I'm going to come back to why that's important to my comments when I get to that. My job here today is, I hope, to present you some of the pros and cons of working through the Medicaid route for this particular issue, where we stand on it. And then I'm going to give a little bit of flavor about states overall, not just on the Medicaid side. So, interest is high, both on the side of folks who want to move this agenda as well as on the Medicaid side. And I'm going to talk for just a few minutes about why that is. The bottom line is, as was represented in Dr. Cawthorn's slides, basically we pay for, in Medicaid, approximately 40% of the births in this country. That is an important part of the equation that you're gonna want to take into account. But we also pay for poor birth outcomes, a lot of them in this country through Medicaid. And so I think both of those have to be taken into consideration. Next, as Will Schrank said, there's a lot of work in states on delivery system and payment reform. This is an active environment. The bottom line is we probably cannot sustain Medicaid into the future as it is currently constructed. That's been generally accepted. We have got to make changes in Medicaid policy, in Medicaid payment, to really address quality and efficiency of care for our enrollees. In that environment, you're seeing a lot of multi-payer initiatives. And the reason I put that up here is that one of the places we have a lot in common in public payment and in private payment for healthcare is in Medicaid. Is for births. We have that in common. When we talk about Medicaid, a lot of times we're talking about long-term care is a really heavy burden on the cost side. That doesn't have a lot of resonance when we talk to private payers. They don't pay for long-term care. But this is a place, maternal and child care is a place where we all pay, both on the public and private side. And so I really wanted to mention multi-payer, and maybe we can talk some more about that. But I think another point I wanted to make when looking at Medicaid is we have a lot of moms in managed care. And that has some potential pluses and some potential negatives here. First of all, we don't have a lot of data about that. Sometimes we're not very good at collecting information on what happens in our managed care plans in Medicaid. I'll be honest about it. But I also think that where there are initiatives going on with private payers in managed care, extending those to Medicaid may be more simplified if they're also enrolled in the same plans. What I'm saying is, if you've got private sector initiatives going on trying to promote home birth in Blue Cross Blue Shield, we have Medicaid folks in there too. So there may be some opportunities to do patient education, to do provider outreach through that mechanism. So these are some qualities about Medicaid that I wanted to make sure we had a baseline on, because I do think that these are some of the reasons why Medicaid is a great opportunity to move this agenda forward. However, I do want to talk for just a few minutes about why it's also a challenge. One is the data collection issues, which I think you've already heard about. We aren't tremendously great in that issue. But I also think that it's important to take a look at who's enrolled in Medicaid. And what we have now is, frankly, a lot of women not in great health. They are more likely to be poor, to have fewer resources generally in their lives, not just in healthcare. They are likely to live in neighborhoods that are not tremendously safe, hard to get to, places your midwives may not want to go. There are a lot of issues with who is in Medicaid that I think is important, both on the health side and sort of the basic side, in the environmental side. But the other thing I wanted to mention too is that we don't have, it's not uncommon for Medicaid women who are pregnant to show up in their eighth month of pregnancy. And that's the first we know about it. So a lot of times I think there are many challenges in leveraging this population. So good side, challenges. I want to make sure we recognize both of those. And I'm actually going to come back to that side. I want to skip forward to a little bit of the issues that are around the future of coverage in Medicaid that are relevant for this conversation in particular. I'm not going to get into the ACA politics on Medicaid. I'm not going there. But I do think it's important to remember that states may or may not expand coverage. Pregnancy coverage in this country in Medicaid, right? It's at a minimum of 133% of poverty. That is the requirement. States must cover pregnant women up to 133% of poverty. About 20 states cover women at or above 185% of poverty, okay? Excuse me. There is a Washington cold. I'm over it, but it's still around here. So what happened when the ACA passed was that those levels of eligibility were frozen, right? States could not raise them and they could not lower them. However, in 2014, they can do exactly that. They can, in fact, lower their rates for coverage for pregnant women down to 133, okay? So what does that mean? That could mean, and this is the part I wanted to raise, that could mean we have women who are cycling in and out of Medicaid and into exchange coverage in between their births. And so this concept of churn is going to become even more critical in the environment, whether states expand, don't expand, have exchanges, lower their FPL. I just think it's really important to get that we may have a lot of churn in pregnant women and we have no idea what that is going to look like state by state. So I don't want to go into that too much in detail because it is really nitty-gritty, but I do think it's worth raising that we do have this picture going forward that will make for challenges in working with women in interconception and other opportunities that you may have. So I know, Medicaid's complicated, and I apologize. I'm going to go back to states for just a second. Because the other piece that I think is the most important policy conversation that you all need to incorporate is that states vary dramatically. And we say that over and over again. I've been in this town working on state health policy for about 13 years, and I do not think that that's a very well understood concept here in Washington. But I think it's really important to remember in this arena. Medicaid programs differ, as I said, eligibility levels, managed care, all of the other components that might differ state to state in the Medicaid programs are really critical. But that's only one component. Health facilities are licensed and overseen at the state level. Those categories of what is a birthing center, what is a licensed, can you have a birthing center in a hospital? Not uncommon. I'm assuming there are some states that go ahead and say, yep, sure, you can do that. So that's another issue that you want to take into consideration. And then, of course, as Dr. Kathleen said, there's the professional licensure, also a state level issue. Has never been determined to be a federal program, and there are no federal standards and requirements for that. And so it does differ quite a bit. And I know you've all probably talked about the community norms, so I'm not going to go into that very much, but I do think that those differ as well. My point for bringing this up is it will be very hard to create a national agenda and a national standard given that variability that will make a lot of sense. And that's kind of where I want to close with my comments, because I'm trying to get us all back online, and I heard a lot of questions in the last session, so hopefully we can have some dialogue. There are data collection challenges. Those have been talked about. As I said, there's variability among the states. And then there's the shifting landscape of coverage in Medicaid in the next few years. So I think here's my bottom line. The temptation would be to say Medicaid should cover home birth, period. But the problem with that is it doesn't incorporate the kind of collaboration that Washington State has engaged in. It doesn't mean that all of the other pieces will be there in place for that to move forward, and that could be actually detrimental, I think. One of the options instead, and I put that forward to you to think about, is creating the kinds of best practices that would help states move forward from where they are and what their current situations are in midwife availability, not much licensure, in their Medicaid program, in their managed care, with their providers. Moving forward in a collaborative sense, I think is much more likely to actually produce the kinds of policy shifts that would be needed to make this kind of effort move forward in the right direction rather than in directions that are controversial without the need to be. So I just wanted to sort of lay that out both as a reaction to the other speakers and to sort of lay the groundwork for a conversation about the interest is high, the opportunity is huge when it comes to Medicaid, but there are a lot of challenges that we should maybe be able to get into a little bit here today that are worth discussing. So those are my comments.